Hello and welcome to the Tompkins NAS Pro Academy. Okay, today we are providing a presentation on insulin. Okay, and insulin is related to one of the rapidly growing comorbidity, yeah, non-communicable disease, diabetes mellitus. Diabetes mellitus could be type 1 or type 2 gestational diabetes, but in the case here, we are interested with insulin, okay? We're saying that it's believed that more than 537 million people are affected by diabetes worldwide. That is something worthy worrying about. So we have to do something, and doing something, we are looking at the treatment, okay? So in terms of the treatment, they're saying that insulin is used to treat diabetes type 1, okay, because of the destruction of the A beta cells, that the body is not able to produce more insulin any longer, okay. But it can also be used in type 2 diabetes, and situations that present such a case could be when, in case you have an illness, you have any other stressing activity or stressing the physiology of the body, like pregnancy, you will be using insulin. Okay, so what is insulin? We're saying that this is a hormone secreted by the pancreatic beta cells of the islets of Langerhans. And this insulin normally facilitates the uptake of glucose into skeletal muscles and the fat cells, guys. And it does this by increasing the number of glucose transporters, that is glucose 1 and glucose 4. So, guys, we know from the physiology that glucose moves from the intravascular space into the intracellular space through the process of simple diffusion. And insulin aids this by increasing the number of the transporters. So, guys, when is insulin produced in the body? We're saying that it is produced throughout, especially in response to food, and that means for those who are taking breakfast, insulin is being produced there. Those who are taking lunchtime, again, insulin is being produced there in abundance. Again, when you're taking supper, again it's produced. But naturally, we have what we call incretins, and incretins will make the body to continuously produce insulin. Okay, so guys, whether you're fasting, you have not eaten, insulin is being produced in the body. Okay? So what are the functions of insulin? It helps muscle, fat, and liver cells to absorb glucose from the bloodstream. And when it does this, it lowers glucose levels. Number two, it stimulates the liver and muscle tissue to store excess glucose. So insulin is involved in the formation of glycogen. Okay. Also, it also lowers the blood glucose by reducing the glucose production by the liver. And the production of glucose by the liver is what we normally refer to as gluconeogenesis. Also, it also inhibits glycogenolysis. Okay, the breakdown of glycogenolysis, and ketogenesis. So those are the major functions of insulin. What are the injection sites of insulin, guys? Guys, we have four major sites of insulin injection where we do inject. Okay? So, number one, we have the abdomen, and the abdomen is one of the preferred site for injection sites. Okay? It provides a good amount of subcutaneous tissue and a large surface area for rotating injection sites. The recommended areas are around the belly button, but at least 2 inches away. That is, those are 5 centimeters away from the belly button. Those are like three fingers, 2 to 3 fingers. Okay. The next site is the thighs. Okay, and you're saying that the front and outer sides of the thighs are suitable injection sites. Again, use different areas to prevent injecting into the same spot repeatedly. The third one is the upper arms, and the back of the upper arms can also be used for insulin injection. This area is might be more challenging for self injection for some individual, so assistance may be needed. The last side is the buttocks, guys. So the outer and upper areas of the buttocks can be used as injection sites. It's essential to avoid injecting into the lower buttocks, as this can be difficult area to reach and may not provide consistent absorption. So remember to rotate injection sites, okay? Remember to change injection site, avoid injecting in visible blood vessels, and keep track of the injection sites, okay? So those are the 4 major injection sites for insulin. What are the types of insulin, guys? Guys, the types of insulin, we have rapid, we have short acting, we have intermediate, and long acting, guys. Okay, long acting insulin. So guys, when do we use rapid acting? Any trial? So rapid acting insulin are abbreviated as LAGs: Lispo, aspartate, and glucagon. It's used to manage blood glucose level during and after meals. It is designed to act quickly to help control the rise in blood sugar that occurs after eating. Okay? So, the scenarios like mealtime dosing. Mealtime dosing. Rapid acting is typically taken just before or immediately after a meal to manage the increase in blood sugar that occurs after eating. It helps the body to utilize the glucose from the food effectively. What about the correction of high blood sugar? If a person with diabetes experiences high blood sugar levels between meals or due to other factors, yeah, like a stress, yeah, rapid acting insulin can be used to bring the sugar levels back to the normal range. What about insulin pump? Have you heard of the insulin pump, guys? Insulin pump, yes? So insulin pump, for individuals using insulin pumps, rapid insulin is the type of the insulin that should be used, okay? So that the pump will deliver a continuous basal rate of insulin throughout the day, and the user can also administer additional boluses of dosage before the meals to correct the blood sugars. So rapid insulin can also be used in combination, and this is what we are going to look at it, guys. So some patients with diabetes may use a combination of insulin types to manage blood sugar levels. So for example, they might use rapid insulin at meal times in combination with long term. Okay? Okay, guys. So from the rapid, we can now have the short acting. Like the short acting, you have the short acting or regular or soluble insulin. And you should be able to appreciate the injection. This is normally injected 15 to 30 minutes before a meal. It's a clear solution, and its duration is 4 to 8 hours. From there, we go to intermediate, and intermediate we can have isofen or zinc insulin. What is the advantage of zinc over isofen, guys? Yes? Advantage of advantage of zinc over isofen? Yes. So you find that zinc will have fewer allergies, okay? Zinc will have fewer allergies, and that's why it's most preferred, okay? Yes. So for intermediate, we are saying that it takes around 8 hours, 8 to 12 hours. So you find that that's why it is normally given twice a day. Yeah, you can see. While the long acting will be taking almost 24 hours, and that's why it is normally given once daily. It's good to note that you can be able to combine intermediate with either short acting or rapid acting. Okay, and we'll be finding reasons why do we combine insulin. Okay, so the insulin combinations. Okay, we have several examples of insulin combination. How many types of insulin combinations do you have, guys? Yes, insulin combination. We have three major types. We have biphasic insulin. Okay, this type of insulin mixture contains combination of short acting and intermediate acting. Why is it referred to as biphasic? This is to indicate that it has two phases of activity. So a rapid acting component for the mealtime coverage and an intermediate acting component for the extended blood sugar control between the meals. From biphasic, we have the pre-mixed insulin, the one that we commonly use, and the one that I'm currently projecting. So the pre-mixed insulin, they come in fixed combination of rapid and intermediate acting insulin. They are named so because the insulin is already mixed by the manufacturer, and the ratio of the components remains constant in each dose. Most common examples, you could have 70-30, 50-50. So 70 stands for the NPH insulin and 30 is for the regular insulin, or 50-50, 50 for NPH and 50 for regular insulin. The last combination is the basal bolus insulin. Okay, so why is it called bolus? It is used to describe the treatment regimen that combines a long-acting, that is the basal insulin, for continuous background coverage. Yeah, remember the incretins are there. They need to be worked on because we'll need insulin to work on those incretins. Okay, then we have rapid acting bolus insulin for the mealtime coverage. So we have three types of formulation. Okay, so for the mixed one, at least we have had a say. We know that we should always draw the short acting or rapid insulin, which is clear fast. So in a case where we are doing the mix, we don't have the pre-mixed. The pre-mixed, the manufacturer has already done it. But what if we have just the NPH on its own and the rapid on its own? What are we supposed to do? You should draw the short acting or the regular insulin, which is clear fast, then follow it with intermediate. Okay, so never mix a short acting with a long acting. Never mix a phosphate buffered insulin, that is isofen, with lente. So those are the major things that we are supposed to be doing. Okay, so someone was asking me, why do we normally combine insulin? Any idea why do we normally combine insulin? Yes. So guys, there are several reasons why we combine insulin, and it's for the advantage of the patient. Remember, this is a common practice in treatment of diabetes, especially for the people with type 2 diabetes who require insulin therapy. So insulin mixtures are used to provide better glycemic control and simplify the insulin regimen, making it more convenient for the patients. Number one reason, we have improved glucose control. So combining different types of insulin in a single mixer can help to achieve better blood sugar control throughout the day. For example, some insulin mixtures contain a rapid acting insulin component to cover meals and a longer acting insulin component to maintain the blood sugar levels between meals and overnight. When you have mixed or combined insulin, it means you're going to have reduced injection. So you'll not be having an opportunity, a chance where you are injecting a patient the rapid acting, again the intermediate acting. Those will be multiple injection, okay, and that will be not good for the patient, okay. As the patient advocate, that's what I'm trying to say. Also, just having one injection, it will be convenient for the patient, especially those who are doing the injection by themselves. It is more convenient for you to have just one injection, and that's why it's important to combine. It also gives us consistent mixing. For example, the pre-mixed, like when you have 70-30, 70 NPH, 30 rapid. The manufacturer has already mixed, so the mixing is consistent. Unlike when the patient is supposed to combine the two, that will not be good for him. Also, the mixing also helps us meet several needs for the patients. Okay. So, for example, some mixtures are designed to use in patients with specific meal patterns or habits, and that's what you need to know about the mixing. So, there are several reasons why we combine insulin, and the earlier we get it, the better for us. So, guys, I have some questions here. So, like the nurse is teaching the client how to administer insulin, which instruction should the nurse include? Okay, so when you want to draw insulin and you have separate NPH and rapid, what are you supposed to do? Yeah? First withdraw clear, then cloudy when mixing insulin in the same syringe. So the nurse should instruct the patient to withdraw clear first, then cloudy insulin when mixing the two insulin. Remember, NPH is cloudy. Okay, so insulin should never be shaken because shaking, and this is a protein, can result into a froth, which prevents accurate dose and may damage insulin protein molecule. Rapid acting insulin should be administered no more than 15 minutes before a meal, because if that is done, then we are going to experience hypoglycemia. The client doesn't need to discard intermediate insulin if it's cloudy. That is a normal finding for what? For NPH. So we have a patient is teaching a nurse is teaching a client with type 1 diabetes who jogs daily about the preferred site of insulin absorption. What is the most appropriate site for a client who jogs? Guys, we have said that abdomen is the most preferred injection site for insulin. So if the client engages in activity or exercise that focuses on an area of the body, that area may cause inconsistent absorption of insulin. So a good regimen for a jogger is to inject the abdomen for 1 week, then rotate to the buttock. Okay. So the jogger may have consistent absorption on the legs or arms with the strenuous running. The iliac crest, we never mentioned it as part of our injection site because it's not appropriate due to lack of loose tissue and subcutaneous tissue in that area. Okay, great. What goal is the priority for a diabetic patient who is taking insulin and has nausea and vomiting from a viral illness or influenza? Obtaining adequate food intake. Okay, the priority for a patient with diabetic who is experiencing vomiting with the influenza is to obtain adequate nutrition. So the diabetic patient should eat small but frequent meals of around 50 grams of carbohydrate or equal food to 200 calories every 3 to 4 hours. Okay, sorry. So if the client cannot eat the carbohydrates or take fluids, the healthcare provider should be called or the client should go to the emergency department. The diabetic client is in danger of complications such as dehydration, electrolyte imbalances, and ketoacidosis. Okay? So guys, this is how we'll be looking at insulin. Remember, for insulin, we have rapid acting, short acting, intermediate, and long acting. And then we have now the mixed and the reasons why we are giving mixed. So guys, I would like to know your reaction to the presentation of insulin. Let us know how you handle it in your facilities. Do you have the premixed or the rapid and NPH are coming separately? And how are you getting to the experience? Okay, you can share with us so that we can be able to see how to improve our presentation. Otherwise, thank you so much and remember to give insulin. Okay, thank you so much.